Trialz with Scott Wiley.
I'd say the reason for orthopedics is that we get to see an immediate impact from our interventions. Patient has a broken bone, we can fix the patient's up walking the next day. And also just the ability to use your hands and also a little bit of your muscle as well to pop hips back in, pop shoulders back in, and to really make a difference in people's lives.
Excellent, excellent. So a little bit of instant gratification for both the patient and the practitioner.
Yep, there's nothing more gratifying than hearing a hip sort of clunk back in after it's been dislocated, and then patients can walk after that.
Very nice, very nice. And so, I know you specialize in the hand. Do you treat other areas as well, or at this point are you totally focused on the hand?
I treat all areas.
Oh, okay.
From a trauma standpoint. So in my group, we all take general trauma calls. So if someone comes in and they have a femur fracture or they have a ankle fracture, well, we treat that. That's something that every orthopedic surgeon can do. But as an elective practice, that's purely hand.
Oh, I understand. Okay, so there are certain things that come in oftentimes in urgent or emergency care that most folks are skilled enough to treat, but then in terms of elective surgery, that's where you really focus on your specialization.
Exactly.
Got it. So let's talk a little bit more about elective surgery. I know this was something that was very deeply affected during the pandemic because some hospitals, or I guess really all of the hospitals in the U.S. put some restrictions on elective procedures. Tell me a little bit more about that.
Correct. So most hospitals, they ceased doing about 75% to 85% of their elective cases.
Wow.
And the reason for that was, well, the resources to run the operating room, the resources to take care of patients, they really weren't there. The beginning of the pandemic really showed us how ill prepared we were. So we really had to triage what we were doing. And it was a time to prioritize which cases needed to be done. So the elective cases, in my case, things like carpal tunnel surgeries, trigger finger surgeries, those purely elective cases, we had to postpone them because we had to make space for the truly emergent cases, the fractures, dislocations, the infections. So we had to go forth with those cases.
Got it. And we were talking a little bit before the show about this concept of elective surgery, because you had noted one of the reasons that you were interested in surgery is because folks come to you oftentimes proactively, wanting to get better. So it's almost ironic in a way that we think of these as elective whenever there really is a condition there that needs treated. Tell me a little bit more about the difference between elective and non-elective surgery for the audience.
Sure. So the elective cases are ones that we do. Let me back up. Hang on. So let's start with the emergent or urgent cases. So urgent emergent cases, those are the ones that require immediate attention. So someone has a fracture and their bone is sticking out of their skin. That's an emergent case. That has to go today, possibly tomorrow. Infections, things that are life-threatening. Really, we try to characterize our cases or group our cases as ones that are life-threatening, and those are the ones that we have to do in a very short period of time. Now, elective cases are ones that do help you from a physical standpoint in orthopedics, but they're not life-threatening. So for example, if you have knee pain and you have knee arthritis and you need a knee replacement, that's an elective case. It will not cause any life-threatening consequences if you don't do it, but it will make your life better. So that's an elective case.
Got it. Understood. And tell me a little bit more about the adoption of technology during the pandemic. I know in our industry, clinical trials, folks have adopted remote and decentralized trials, something which we had the technology to do for a long time, but it simply wasn't adopted. Tell me how telemedicine was adopted, particularly in surgery, where there obviously has to be hands-on care.
Definitely. Telemedicine was something that was a little taboo prior to COVID-19. Telemedicine was used in dermatology, so there was something called telederm. And the reason for that was, well, patients could take a picture of a rash or a skin lesion, send it to a dermatologist. They could figure it out usually without seeing the patient. Another field that used remote technology was radiology, diagnostic radiology, because usually a radiologist is looking at just the x-ray. There's not a clinical picture that is as important, or if there is a clinical picture, it's usually one or two sentences. So in radiology, Oftentimes, this would get diagnostic radiology. This would get outsourced to a different part of the state or possibly even a different country, and they would get equal outcomes. So that's where telemedicine really got its genesis. Now, fast forward to COVID. Prior to COVID-19, about 3 to 5% of visits, office visits, were telemedicine. And then COVID forced us into this situation because we were not able to see patients in the clinics. They were closed down. We had to figure out a way to still deliver high quality care, but also make sure that the patient and the staff and the physicians were all safe. And so we adopted telemedicine. So there are some aspects of telemedicine which just might be a phone call, but then we also determined how to use HIPAA compliant video visit software to go ahead and have this have a clinical visit.
Got it. And sometimes things. This may be a taboo subject, but sometimes things come down to the dollar. Was that at play too? Was there a matter of just not having the right billing codes for some of these telemedicine remote visits? How did all that work?
I suspect there was. In my practice, that's not an issue because with Permanente medicine, everything is it's capitated and it's all taken care of. So for us, we don't look at the patient and equate that with dollar signs. We're all about just delivering high quality care, which is a feature of Permanente medicine. For other practices, I think that was an obstacle. And that was probably one of the reasons why we've been so slow to adopt telemedicine. But now, since it's been forced upon us, there's no going back.